going on, everybody? Welcome back to another episode of the Core Consults RX podcast. Cole and AJ in the studio talking about a new topic for the day.
Plaque psoriasis.
Plaque psoriasis coming at you and coming at you quick.
You know, I'm a little disappointed, not about the topic, but about false fall. We kind of just had it last week.
Yes.
It felt really good.
It did. You know, I was just like, why would you do that to me?
You know, with age comes wisdom. I didn't even get slightly excited about it.
Really?
I knew what it was.
Oh.
False fall.
Really? Nothing gets past you now.
No.
Too wise.
I've too wise.
Got right past
I've
me.
got 2 eyes.
So I actually, the thing about it is I actually disproved that theory because I'm way older than you. And I was immediately like, woo, winter is here, baby.
Then I got in my truck at lunch today.
And almost had a heat stroke. Yeah,
Yes.
me too. It was terrible.
Hot.
AJ, what are your thoughts on the weather?
I bought 3 pumpkin spice candles, so I guess the age thing is spot on.
So Anna likes this pumpkin spice Myers All Day cleaning solution. It brings it out every fall, but they don't stock it anymore. And I can't say that it's my favorite scent, so I can't say that I was too unhappy that they don't stock it
But you got to pretend for her sake.
Well, yeah.
Kind of.
It was hard for me to hold in my glee when she told me it was out of stock.
Glee.
She's like, I thought you liked that. I was like,
Oh, I do, but it's just not like...
or this is what she said. She said, you said it reminds you of fall. I said it reminds me of fall. It doesn't mean that I like the smell.
Yeah. Stuff could remind... fall. Yeah, my house could be on fire and it could remind me of a nice bonfire in fall. It doesn't mean I'm happy. Anyways, plaque psoriasis, an obvious sort of transition here. So we are going to do a really brief overview of some of the medications that have been around for a long time for treatment of plaque psoriasis. We're going to save like our more in-depth discussion for these when we get and partner with Free CE to do a actual accredited episode for this that we can do a full hour on. Not that we couldn't do a full hour now, but we don't want to take away that topic from continuing ed opportunity. So we are actually going to focus more so on the 3 new meds that have been approved over the last 4 months or so. We'll give you, like I said, a brief overview of some of the classes that have been around, but we'll come back and we'll do an episode in the near future where we really dive into those.
Yeah.
But there's just been a lot for plaque psoriasis approved as of lately.
There has been. But the briefest of overviews because we want to focus on the new
briefest.
ones. The briefest we've ever done.
No, maybe.
I don't know. We're not usually that brief.
Yeah, I feel like it's going to drag out, actually.
Well, we'll see.
It's my fear.
Are we 5 minutes in yet?
I don't know. AJ, check the time. We're trying to get out of here.
2 minutes 45.
Okay. Wow, that wasn't too bad. So,
intro did not last long enough.
Plaque psoriasis, briefly, chronic skin disorder, has erythematous papules and plaques with a silver scale. In most cases are treated outpatient. It's not particularly severe. There's a number of things that you can use. Moisturizers are one. They're used adjunct to the psoriasis treatment. Keeping the psoriatic skin soft and moist can minimize symptoms. Most effective emollients are ointments like petroleum jelly and thick creams. And the recommendation is to apply them immediately after a bath or shower. But other options are Aquaphor ointment, Vanicream cream, Eucerin. You've heard of all these. And then certain body washes like Dove bar soap and Aveeno body wash.
And I think the important thing to also consider too is a lot of those that Cole just mentioned are like hypoallergenic and unscented. The Dove has all kinds of different scents, but the one they would recommend in this case would be the unscented, so that you don't get irritation from the skin from the fragrances and stuff like that.
Right. Riddle me this.
Okay.
We get unscented laundry detergent because of sensitive skin purposes, but then we buy those scent beads and toss them in with the detergent.
Who does that?
Well, I'm not going to place blame. I'm going to say
we.
That's I was trying to get him caught in it. I tried. Sorry. I wouldn't want to say we're obviously a unit, so it's a team effort. I just can't. I just shake my head as they get purchased. Do you guys have any issues with?
No.
Well,
it just makes me wonder. What if we got scented detergent and didn't pay $20 for the big
I think what we've actually proved is that Anna knows best, and you need to quit questioning.
That's true. I shouldn't question.
Now, if you wake up tomorrow and you're just covered head to toe in a rash,
then
we have a leg to stand on.
She says that it's not less allergenic, she says. We're not having skin issues.
She's a smart girl.
She's smart.
She's probably a lot smarter than both of us, to be honest with you.
That's very true.
So, I'll take her word for it.
When you said unscented, I thought of it.
No, that's my wife also likes those in the thing.
The beads?
The beads in there, yeah.
Do you think they make a difference?
I don't know. I can't tell. I'm a guy.
I used to have a super sniffer, and I used to know what stale clothes smelled like. But since I had COVID, no super sniffer anymore. It's like I don't even notice.
You're retired.
COVID
took you out.
Retired the sniffer.
It's all right. Well, we'll find your new talent.
Thank you. My next talent's going to be doing the briefest of overviews. So
already not off to a good start.
There's also topical medications that can be used, corticosteroids, whole variety of them with different potencies. We'll go into more detail on that on another episode. Different vehicles. There's also calcineurin inhibitors like tacrolimus and pimecrolimus. That's Protopic and Elidel. And then there's vitamin D analogs as well, like calcipotriene and calcitriol. And then there's retinoids like tazarotene. And is that the only retinoid?
Yeah, that's the one that's like specifically has the data in plaque psoriasis. I'm tends to be a little bit more effective sometimes in that case, but whereas like tretinoin and those, you probably wouldn't get as much efficacy. But I'm sure that there are cases where people use that. More sensitive skin and things.
And 2 of the new drugs are topical, which we're about to talk about. But before that, there's also Antherlin, which is Dritho cream. It's a direct anti-proliferative. It has a direct anti-proliferative effect on the keratinocytes. Is it
keratinocytes? Yeah,
that's how you say that. It's
just the thing about you, Cole, is you just instinctually pronounce things correctly.
I don't know.
I like that.
Well, what felt instinctual was I'm not even gonna say it because it's wrong. Yeah, keratinocytes. Good.
All right. Well, you know what? Could have been a good outtake, but that's all right.
Yeah, because we would have edited it out for later.
Yeah, I would have forgotten where it was. It would have been never mind. We went too far.
Yeah.
So yeah, like I said, we'll go back through those, but those all have been used for quite a long time, and really like the kind of hallmark treatment is the steroid, topical agents that. They are utilized for at least 2 to 4 weeks, sometimes longer, depending on the area. And that's one of those things that has a lot of side effects potentially. And that's really the problem with a lot of these. Steroids, can thin out the skin, depending on where it's located. You have to really pay attention to the potency. With things like the Tacro, the Elidel, the calcineurin inhibitors, those have a risk for like certain malignancies and things, rare as it may be, that's still a risk. And those would be more indicated for, more sensitive skin areas. So it's better in that case from like the skin atrophy or skin thinning and whatnot from the steroids, but then you have all these long-term potential complications. Tazorac can really affect the skin negatively. And so it's one of those things that topical seems to be like at first glance, like, why are we still going that route when we have biologics and, small molecule biologics, things like that. But it's like, there is definitely some room. And I'll show you when we get into some of the new topicals, some of the data, it looks actually pretty surprisingly good. So we'll pull some of that up, and we'll show you some of the graphs that were presented like from the drug companies themselves, because we got a new and improved thing on the video now.
We do.
So we can screen share.
For you YouTube users.
Yeah.
You're going to see it.
So I'll give AJ the signal when I need him to pull it up.
But we didn't talk about it much, but plaque psoriasis is a lot of times localized to certain areas, right? It's not like a full body situation. So that's why you can effectively use the topical agents.
Yeah. All right. So we'll come back to the topical agents when we go over the other 2.
Okay.
We'll finish up just going through some of the older meds that I'm sure all y'all have heard about. If that's cool with you, Cole.
Yeah, let's do it. So there's systemic non-biologic therapies. These are older drugs that you're familiar with. Methotrexate is an option. Don't use it in pregnancy. There's also newer ones like Otezla. Apremilast is a PDE4 inhibitor, an oral medication. There's cyclosporin. All sorts of labs and monitoring to be done with that, of course. But that's also used along with a different retinoid-like compound, oral compound, acitretin.
Yeah.
Soriatane.
That's the one that I think of almost as like Accutane, because it's got the pregnancy category. Like you have to, make sure that the patient is. You have to avoid pregnancy during therapy and for 3 years after stopping the medication is like the recommended duration, which is like holy cow. Same thing like blood donation for men and women. It's not permitted during and for at least 1 year after treatment. This is one that I feel like I've only seen maybe 2 times actually utilized.
Never seen it.
But I'm pretty sure, I want to say that this one has like an interaction too with like, I want to say it's like doxycycline, where it can cause like intracranial hypertension. AJ, will you check me on that? I don't know why I remember that. It's probably wrong, but
AJ's like, why are you making me do work? I got to switch the screen.
You're my Googler, dude.
I got to Google.
AJ is very, very multitasking oriented, so he likes this. So yeah, but that's one that it's still out there. It's an oral agent, but I feel like the ones that you're going to see more commonly from an oral standpoint would be the methotrexate or the Otezla.
Right.
Although Otezla's price is not exactly
Nope.
great.
Still commercials for that. So if you're seeing commercials, it probably means it's expensive.
Pricey.
So those are non-biologics. There's also biologics, all the monoclonal antibodies, the MABs, and different things. So there's TNF alpha inhibitors, Humira, used for all sorts of things. Also Enbrel, Remicade, and Cimzia. Talk about those in more detail later. But all of these are pretty effective. I think that Remicade is IV, and then the other three are sub-Q. Is that right?
Yeah.
Okay.
And you probably heard us when we talked about, I think we did, it was either Crohn's or something we did where we talked about those, the TNF alpha inhibitors. But they have a lot of risks and things with them as well. And so one of the things that people will ask is like, well, why wouldn't we just use like methotrexate where, we're worried about pregnancy and things like that, but also, just maybe monitoring the liver, but there's not a lot of like hardcore infection risk and things like that. But just to give you like a quick example, and like Cole said, we will go into this in much more detail later on, but the Champion trial was looking at methotrexate versus adalimumab or Humira, and also placebo, comparing them. And basically the methotrexate had a 36% reduced relative risk reduction, 80% with Humira. So it's pretty significantly more effective than some of these older non-biologics. So again, it depends on how the severity of the patient's, area of that's been affected by it. But I saw a patient myself in clinic, they were trying to figure out what we could get access to, and his arms had so many of the plaques on them that it basically could not see healthy skin on his entire arm. And we got him set up with Humira, and within like 2 months his arms looked completely like healed.
Amazing.
I mean, not, you could still see where some of it was, but it was like night and day difference in 2 months. It was crazy.
It's good.
And so, yeah, they're very, very effective. And sometimes you unfortunately have to kind of take some of those risks about the long-term stuff.
Right.
When to debate now is when to stop them.
Right.
Just giving all kinds of cliffhangers, Cole.
For next time.
Really trying to
drum up the pressure for the next one.
Right.
So there's a number of other monoclonal antibodies, and I was going to say I'm not going to list them, but I am, and I'm going to say all of the generic names just for fun. So check me,
Here
Mike.
we go.
Okay. These are all interleukin inhibitors. They're gonna target specific interleukins. So there's Skyrizi, risankizumab, Taltz, ixekizumab, Salik, brodalumab, Tremfya, guselkumab, Cosentyx, secukinumab, Stelara, ustekinumab, and Ilumya, tildrakizumab.
Yeah.
Nailed it.
I think that was good, man.
All but brodalumab.
Yeah, and who cares about
Screwed
that?
it up.
The other one, when's the last time you saw somebody prescribe that?
I know.
Exactly.
Well, Salik, I've seen it, but
Yeah, I mean, very rarely though.
Yeah,
Come
sure.
on, Skyrizi? That's a way cooler name.
yeah.
Also, Taltz is in my favorite Trulicity pen.
Oh yeah.
A really long.
Oh, you
Trulicity
mean
pen.
the
device? Yeah, the auto injector.
Yeah, kind of like Emgality. So I
Yeah.
guess it's a Lilly.
Yeah, it's a Lilly device.
Nice.
I helped them come up with it, and then they've just been using it ever since.
They call it the Corvino.
Could you imagine? It's just a fun fact I throw out there. Yeah, no, they didn't ask my help.
Casually name drop.
When I was working as an engineer for Lilly, way back when,
I told them I don't want to see that needle.
I'm scared to death of
I
needles.
don't want to see the needle.
If I see one needle, I quit. I'm taking my expertise with me. There is a pretty good meta-analysis that does comparisons of the biologics as well as some of the oral treatments that can be used for plaque psoriasis. That was published in JAMA Dermatology. I like this because there's so many different options now. And we're about to add more to this list, obviously. But this kind of gives you at least an idea based on that meta-analysis. The likelihood of the improvement. So they have it broken down by the severity index 75, severity index 90, and severity index 100, and you can kind of see the differences between the different the agents and all that, and how many patients in those groups actually met that criteria for, say, PSAI 75. So it's pretty interesting, and it kind of gives you a hierarchy of how to kind of look at that. So no surprise that the newer meds are all towards the top, just getting more and more effective
And safer. Well,
maybe
maybe not long term.
Yeah, we'll see. That's the best part. We don't know. It's just a big mystery.
Right. Hopefully better than methotrexate.
We're trying to get
and
AJ to
cyclosporin.
hurry up and get his PhD so he can invent something cool, and he can name it after me and Cole.
You will
for
not
really
be
being
able to pronounce it.
for being basically his like icons kind of thing, right?
I mean,
Right? His
Idol.
words.
yes, quoting AJ.
I'm quoting AJ when he wasn't on camera.
He's gonna call it the core consult.
That's not hard to pronounce. People will still be like, "Why the heck is it that's a dumb, that's a
Name
stupid
that.
name that doesn't exist in the English language."
What's your website? Core Consult RX. How do you
Yeah, like
how do you spell
CORE?
that?
No, it's like Corvino, like my name. Like I didn't think it through. Whatever. You know what? You guys listen. I don't care. All right, you want to jump in some of these new ones?
Let's do it.
Let's see. Let me go back up my slides. So this is one that kind of actually surprised me a little bit when I saw the actual active ingredient.
Yeah.
Because it's a topical agent, but it is roflumilast, 0.3% cream, or Zoryve. It was approved in July 29th of 2022. It's approved for patients 12 years of age and older. And if it sounds familiar, it's because we've had an oral version of this for quite some time. So it's a phosphodiesterase 4 inhibitor. And when you inhibit that PDE4 enzyme, you're basically going to start accumulating cyclic AMP. However, with plaque psoriasis, how it actually exerts its therapeutic action isn't exactly understood, which is always my favorite mechanism. Like, I don't know, we just figured it out and it works. We don't know how. The good thing is it's applied once a day, which I feel like almost all the other topicals that have been around are twice a day, including steroids. And it has very, very few side effects, if any. In fact, the studies that were done with this showed very little difference, if any difference at all, from placebo. Maybe a little bit of GI upset if you put enough of it on, I guess. But almost nobody had issues with the adverse effects, and that would keep them out of the study. And the other thing is, from a long-term standpoint, kind of going back to that, we've had roflumilast orally, which is way more systemic absorption forever in COPD. And that drug's been out for a long time, so we're pretty sure it's safe. At least we would have probably seen something post-marketing at this point.
Right.
So I feel like this is one that definitely has some good potential with it.
Yeah, and it has some interesting data. So there were 2 trials, the Dermis 1 and the Dermis 2 trials.
See what they did there?
Really nailed it.
Nailed it.
I
know what the dermis is.
I want to know what the acronym is, and I've got to know.
I'm going to do skin 1, skin 2.
I know. I got to know if it's good or not, the actual acronym, if it matches up. But
I bet you it's not even anything to do with those. They probably just picked dermis.
Oh, sure. And I mean, you should.
That's what I would do.
But that's so lame, though.
Cole, you're going to be so upset.
Give it to me, AJ.
Trial of PDE4 inhibition with roflumilast for the management of plaque psoriasis.
That's so lame. You can't just go naming stuff whatever you want for advertisement purposes. There's some
Sure as
kind
that can, Cole.
there's some kind of
It's
commercial.
in the Geneva Convention.
Next episode, our thoughts on Dermis 1.
Yeah, our next episode, our thoughts on naming things.
There has to be.
That's when we lose all of them.
There has to be some implicit bias there.
Or they just like,
It's
they're
like,
like, hey, we're dermatologists.
I mean, it's good. It's marketing, but I don't know. It's silly, man. Then come up with a better name for the trial, and then name it Dermis. Like, I'm not gonna go there.
Okay, no, you should definitely.
No, you name it.
We'll
You name
wait.
it.
We'll wait.
I'll think on it.
Okay.
Come back with the next Plaque Psoriasis episode. It's another cliffhanger we can wait for.
I don't know. I wouldn't want to wait on that one.
Anyways,
Yes, Cole. Please tell us about the trials.
so they're phase 3 trials, looking at once daily roflumilast cream, 0.3%, which is the new drug, in patients 2 years or older with a body surface area burden of psoriasis 2% to 20%. And that's frequently how they grade that along with other assessments. Primary endpoint was investigator global assessment success. They call that the IGA, which is clear or almost clear IGA status, plus a greater than or equal to 2 grade improvement from baseline at 8 weeks. So basically saying that based on this assessment, they have improved X amount to say that this is effective. They had secondary endpoints with different assessments looking at itching and severity index and that sort of thing. About 3, and this is looking at roflumilast cream plus a placebo vehicle, of course. So somebody's going to be applying. I wonder what it was made of. You know what I mean?
like lanolin.
Yeah, well, I mean, I guess the moisturizer's got to be a
Yeah.
little bit helpful, right?
Just maybe.
Maybe.
You're just kind of like waiting for the itching to stop. And you're like,
Well,
it's not getting better.
I wouldn't want to. I guess it's probably the exact same cream that is the exact same vehicle that's in the roflumilast without the active ingredient, I'd
Right.
imagine. Okay. So it's not like they're
yeah.
using Eucerin or something like that.
Probably not.
Which is obviously an ointment. Anyways,
Cole knows his OTCs. I like it.
I know I'm right. About 3/4 of both treatment
It's the
arms.
cockiest I've ever seen, Cole. That's amazing.
It's because
AJ, mark time starts.
It's because I do not, because we would dispense Eucerin from behind the counter. So that's why I'm more
I know.
familiar
But I'm
with it.
so proud of you right now.
Thank you, Mike. We also literally just talked about it 5 minutes ago.
Did we?
We did.
You don't pay attention.
So approximately 3/4 of both treatment arms reported a baseline IgA score of 3, which is considered moderate psoriasis disease. But the results at the 8th week, about 40% of patients with the treatment arm achieved success, IgA success, versus only 6.5% in the placebo vehicle, which was statistically significant. So that's pretty good.
Yeah.
And of
I like
course,
it.
it's only against placebo. I wonder how it would do against the oral form, but it would clearly not have the long-term adverse effects that the oral form has.
Yeah,
right?
with the weight loss and all that. But that is interesting. I wonder if they actually saw
better results.
Better, if people just happen to have, had comorbidity like psoriasis, if they saw improvement. I wonder what even made them. I don't
try to do it topical.
I'm asking the question out loud because
My
I could
guess
easily
is
just Google this. But
my guess is safety profile. I mean,
Yeah.
anytime you can have something topical, if it's still effective, it's going to be.
Yeah, I'm
generally
just
safer.
wondering if that's how they initially discovered that this could, because they don't know how the mechanism works. If they just noticed that people's psoriasis was getting better when they were taking it for COPD,
Oh, I see what you're saying.
and they were like, "Oh shoot,
Yeah.
let's make this into a cream."
I mean, it's like Botox with migraines,
Yeah.
treating the wrinkles and, hey, doc, my headaches are actually a lot better.
yeah.
But
Plus,
I'm also
I have-
looking great.
I was using my spear gun, right, and then get some Botox. It's the puffer fish toxin. That's a real thing. Don't look at me like I'm crazy. AJ, back me up on this.
It's a real thing.
Thank
It
you.
is. But Mike does ask questions that he knows the answer to during the podcast to make himself sound smarter, because every question thus far is checked out.
Is that where the Botox comes from?
First of all, AJ, what that was?
toxin.
What
It
an
is.
what
Well, I
an
know it's a toxin, but I thought it was derived from Black Widow venom.
No,
Am I crazy?
That's
No, that's
you're
pufferfish.
crazy. Yeah,
Isn't
It's pufferfish?
Yeah, wait. First of all, we're not just going to blow past that outlandish accusation
That
that,
was
AJ just.
100% true.
What are you talking about? I
100%
ask myself questions that I already know the answer to. What is this, grand rounds?
Mike's like, the sun came up this morning, didn't it? AJ, check that out. Check that.
That's
real
it,
quick.
dude. AJ, you know what? I'm so disappointed.
And then he waits for my response.
It's called being that's called
yep.
being a backstabber. That's what that is. So disappointed in AJ, everyone. So if you see AJ, just don't even talk to him next time.
Checks out. It did this morning.
I swear that there was some relation with Botox and Black Widow venom. Maybe
Look it up.
It's
maybe
contraindication.
Are we allowed to ask you to look that up,
Yeah,
AJ?
so you're
May-
not allowed to be bitten by black widows while you're on Botox.
Listen,
Who's
yes,
actively
AJ,
getting
I'm asking
bit?
you a question that I don't know the answer to, but yes, look it up, because maybe it's that Black Widow venom acts in the same fashion neurologically that botulinum toxin does.
Why would you be getting actively bit by black widows if you're getting Botox?
So
It
Don't
doesn't
go
have
out-
anything to do with Botox.
Don't go outside.
saying-
Be careful.
All right,
Wear shoes.
AJ's gonna find out.
Wear shoes in the house.
right, I've got your answer for you if you're ready.
Okay, tell me.
Is Botox from Spider Venom? No, botulinum toxin is a synthetically produced substance.
Well, I knew it wasn't from spider venom, but I thought there was some relation.
They
with
milk
how
the
they
spiders
act.
individually.
All right, they do it for snakes, so don't act like that's crazy.
But spiders are so much harder to milk. They're so much tinier.
I bet they could do it.
You have to use tweezers.
All right.
We are so far off
We just
topic.
we just gave misinformation on Botox. Thank you for fact checking us live, AJ.
Wait. So we were saying yes, it's made synthetically now, but we're saying it never came from pufferfish? What?
No, that was good. That was good to go.
Okay, I thought so.
Oh, do you look that up and verified?
I did.
Okay, thank you.
Yeah, you should have seen the look Cole was giving me when I said that about the blow dart. He's like, "What are you talking about?"
Well, what does that have to do with a blow dart?
Because they would stick the dart on either they use the poison dart frogs. Have you not seen any movie on the Amazon?
I know the poison dart frogs. So what does this have to do with a pufferfish?
Because then you get the liver of the pufferfish and you stick the thing in there. Have you not? Oh, dude, I got so much to teach you about
You didn't
survival.
watch the Goonies.
Yeah.
I actually I'm finished. Would you watch Alone on Netflix? Oh, you should.
Is it good?
Survival show. I think it's good.
Some of those end up being the same kind of thing.
It
And
is.
I'm
I mean,
you
this
probably have granola bars behind the scenes.
it's pretty. This one's pretty legit. They lose like 65 pounds. It's pretty wild.
That's cool.
Yeah, they're like amateur professional survival people. They stick them out there alone with some cameras.
I
pretty
self-identify as amateur professional in a lot of things. So
Yeah,
I can relate
you
to
sure
that.
do.
I meant to say that they're not
I
like
also can't classify you as
they're
that.
not like Bear Grylls professional.
Oh, he's so cool.
I'm saying in that way.
I see myself as more of a Bear Grylls character.
But for their day jobs, they do something related to like
They work at AT&T.
they do something related to survival.
Oh, God, sorry.
Yes.
Gotcha. Bear Grylls does that. He does that for real. He doesn't work at AT&T.
I'm sure he does.
But those people, I feel like they have a regular job. Anyways, AJ, let me find my screen real quick. Because I want to show this graph real quick. This is something that was presented at the. Can you pull my screen up real quick, AJ?
There we go.
So this was now the way that they did this isn't 100% correct as far as statistics go and stuff, because it was looking at the different studies that have been done with different topical agents and kind of looking at how the improvements they had from baseline. But you can kind of see roflumilast is on the far left, and so when they're comparing that to, like, for example, the steroid plus the vitamin D agent, then you can see that the roflumilast tends to be a little bit higher as far as the percent, of patients that got that met the criteria for improvement. And then they looked at, again, the Tazorac and the halobetazole combo. They looked at one that was of various products, monotherapy and combos. And, just basically showing that this one does seem to have pretty good efficacy. Now, again, we would have to have true, like, head-to-head data. Obviously, this is the company that makes roflumilast, so of course they're going to make their drug look better. But, from an 8-week standpoint now, my question would be, after 8 weeks, do these start to all level out? Because the stuff's not cheap. And so, I think that that's probably something that we'll, have to look at. But if you look at, which we're going to talk about the other drug, they also compared the other new topical agent directly to roflumilast. And roflumilast also seemed to be a little bit more efficacious from their 8 weeks point of view versus the 12-week endpoint of the other new drug. So something that, they're at least trying to show that there's some benefit, but that's all we got to go off of right now. We don't have any good head-to-head data.
It's good.
Just want to throw that out there.
Everybody on YouTube can see how many active applications Mike has running right now.
All of them.
Command Q.
Okay, here's the thing about me, dude. I'm currently writing the greatest midterm exam you've ever seen for my PA students. That's why I have so many things open. Because I want to make sure it's perfect.
Takes lots of applications.
They're all PowerPoints.
I'm over here wondering how many people I mentioned that whole Botox and Black Widow Spider Venom thing to.
Cole's still worried about that.
The only thing that I can think that associated them in my mind is that they're both neurotoxins.
Yeah.
That's the only thing I can think.
Did you tell your students on rotation that?
I don't know, AJ.
That might have
It
been
could have
the
happened.
Naplex
I feel
question
like
that
It
failed
could have
them.
happened.
I feel like if that's the worst mistake you ever make, you'll be all right. Because nobody is going to care.
I'm fact checking that every day, no matter what you say, no matter how you are.
Fact checking
true.
the Spider Venom. You shouldn't have to fact
Like,
check
you mean the
it.
students should fact check is what you're
Every
saying?
time.
Oh, yeah. Well, I encourage that for all
Well,
students.
okay. I would say that if it comes from pufferfish and I accidentally said Black Widow Spider Venom, then not too bad.
Yeah, this is basically the same. It's like a lobster and a camel. Same thing.
I mean,
Why the same basic animal.
The camel is the cockroach of the desert.
I
Says who?
don't know that that's
Says
a
who?
term. Is that a saying?
He's
AJ, Google that.
He's over 2.
Yeah, it's Cole. You are really you're digging deep here. This is worse than that one time you said 80 billion people died from the flu, right?
Jeez.
Oh man,
we didn't have AJ back then.
Yeah, it's true. We really had no fact checks.
We were off the rails. So we have talked about one of the new drugs, which is roflumilast cream.
Yes.
The second one is, the brand name is Vtama.
Mm-hmm.
It's tapinarof 1% cream, approved in May. One thing I do want to point out is, drug names, they like to put this letter at the front of the brand name that wouldn't make sense, like to say Vitama, because that's not how you pronounce it. So it's a hard Vtama, I bet. Like Excopri, it's not Scopri, it's Excopri, or even Qulipta is not Qualipta, it's Qulipta. They like to do that. Isn't that interesting? You don't see that other places in the English
They want it
language.
to stand out.
I guess.
It's not. Maybe it's Latin. We don't know.
Maybe. So Vtama, it's a topical aryl hydrocarbon receptor, AHR modulating agent. It may improve psoriasis, they're not entirely sure, through modulation of T helper type 17 cell cytokines, or T helper type 17 cytokines, and then IL-17A and IL-17F. Also normalizes the skin barrier, has antioxidant activity, and there were a couple of trials.
The soaring one.
There's
soaring
no
two.
way that this matches up with the
Oh, here we
acronym.
go. Cole just can't let it go.
I can't. Soaring
starts
with
with
a P at the front.
It's psoriasis.
Silent P,
Cole.
soaring.
Oh, that's so clever.
Oh,
so
that's
clever.
ridiculous.
It's like how do you know it wasn't the psoriasis study, ostrich, and I don't know. But
They tried to make it clever with the silent P.
remind me if we ever do a clinical study not to let Cole be involved with them, but we'll be there forever trying to come up with an acronym.
Golly.
You gotta let it go. It's okay. It's just a word.
Oh
Soaring.
no! Oh no! Oh no!
What?
What do we got?
I think you're gonna like this. Cool.
Oh, am I?
Am I gonna hate it?
So we've got proportion of subjects who achieved a No. I thought it was there. It wasn't.
It's not. It doesn't even say psoriasis at the
No.
beginning.
It doesn't even have psoriasis in it. No.
Yeah.
What are they thinking?
I didn't know what age he was talking about. He's just like, no. I didn't know where he was even going with that. He was looking up the acronym.
So what were these two trials?
The Soaring 1 and Soaring 2 with a P.
Silent P.
Cole, you're going to have to let that go. But just to mention some of the adverse effects, they did note that in the tapinarof group, they had more instances of folliculitis, contact dermatitis, as well as headache compared to placebo. The other thing to mention is it is also once-a-day application. So they figured out that once-a-day administration sort of schedule. It seems to be the future, apparently, of topical psoriasis measures, because they've always been twice a day, I feel like, since these things started coming out.
If I could name a study whatever I wanted, I'm just going to call it Best Drug for Psoriasis 1 and Best Drug for Psoriasis 2. I mean, like, if we can just do whatever we want now.
Yeah, but I feel like that's like too obvious.
Oh, is it?
Yeah.
So what about soaring
Like, if
with a
I saw
silent
that,
P? I mean, where's the line?
This is the thing. If I saw that, I'd go, I'm never using that drug. I don't care how good it is, because that's a stupid name.
I don't know. I see soaring and I don't see letters to
I
match
go, that's
in the
clever.
name.
That's what I say, because I'm a very understanding.
But why soaring then?
I don't know. It's stupid. I don't care. I just want to know that the drug works. And it turns out it may not even be as good as the first one we talked about. So
That's 'cause
whatever.
It's a stupid name.
Yeah, well, that's a theory. The CEO is just like, what are these guys talking about?
But yeah, so you had, there is a suggestion that just looking at the results from each of them, that the roflumilast cream may be slightly better. Is that right?
Yeah, I mean that's what the roflumilast folks are trying to get you to see with this picture. Again, you can't compare data like this. However, it gives you something to look at, I guess, since there's no head to head.
Right. And they had different links of the study.
Yeah.
Yeah, there's no way to directly compare it. So
But it's on a slide that they presented, so it's like they really tried.
Oh, I'm sure they did. I'm sure they did.
A for effort, guys.
So those are the two new topical agents, right?
Yep.
So there is a new oral agent.
What?
Yes, there's a new oral agent. If I can find it. I really don't know how to pronounce this one. Sotyktu.
Yeah.
This is hot off the presses, September 2022.
Yep.
Generic is deucravacitinib.
Yep. Nailed it.
Moderate to severe plaque psoriasis who are candidates for systemic therapy or phototherapy, because this is a systemic therapy. And it's a tyrosine kinase 2 inhibitor is its mechanism of action. As far as side effects and warnings to be aware of, it's actually reasonably well tolerated, but can increase your risk for infection. Also upper respiratory tract infections as well, pneumonia. Other than that, I mean, nothing is too particularly significant. There's some like dermatologic irritation and things like that you could get. So increased risk for infection is the primary thing. So that's good. Safety profile is pretty good. Of course, it's
another oral agent.
Another oral agent, newer drug. It had two studies which I guess that this is probably biased names as well, but it's Poetic PSO. I guess if that's a silent P, it might be Poetic So. Poetic PSO1 and Poetic PSO2. So these were two pretty long, year-long phase 3 studies looking at safety and efficacy of this drug, 6 milligrams once a day versus placebo at week 16 and versus apremilast, 30 milligrams twice a day through week 52 in adult patients. This is moderate to severe plaque psoriasis. They had to have a body surface area of psoriasis involvement greater than 10%. And then the psoriasis area and severity index score that we talked about a bit, greater than 12, just saying that it's moderate to severe psoriasis. And then a couple of other assessments related to psoriasis. There were two co-primary endpoints. They both assessed the response at week 16 compared with placebo. For two co-primary endpoints, the proportion of patients who achieved at least a 75% improvement in the PASI score from baseline, and the proportion of patients who achieved a clear or almost clear score on a different score scale that they look at. Results being that with those co-primary endpoints, the psoriasis severity index at week 16 versus placebo, the treatment group had 58% achieve a positive endpoint there versus 13% with placebo, which was statistically significant. That was in the first study. In the second study, it was 53% versus 9%, so reasonably significant. And then they had similar responses with the other clear or almost clear score index that they looked at with both of those. So versus placebo, it seems to look pretty good. Their secondary endpoint was versus apremilast, and in the first study, the severity index score was 58% for the study group versus 35% for apremilast. And then in the second, it was 53 versus 40, and they did have those as statistically significant. So at least based on those studies, this one seemed to have beat Otezla, but I'm sure that it doesn't tell the whole story.
Well, and honestly, I mean, I feel like I haven't heard super great things about Otezla anyway.
Yeah.
In fact, I remember one of the new drug update conferences that Dr. Wirt puts on, but the dermatologist that spoke, he said it's super hit or miss with his patients. So that doesn't surprise me. If we have a better mechanism and you're getting better results, then that does make sense.
Yeah. So I mean, if you this is just at week 16, you're looking at 20% more patients, 15 to 20% more patients that are going to have a positive response.
Mm-hmm.
It's pretty good.
Yeah. I dig it.
Yeah.
I will say that I just looked up the average wholesale prices on the two new creams. The roflumilast is about 1,000 AWP, and then the other new, the Vitamo is 1,500 AWP. And then this one that Cole just mentioned is actually not even, I can't find it yet in our ordering system because it just came out on the 9th.
If it was just approved on the 9th, yeah, it might be a few months before it's actually available. I wonder if they list an AWP.
I want to be the first person to have it.
LexiComp, but no, I don't see
nothing.
No, I don't see one. So it's probably not actually commercially available yet.
So the next question is, when are they going to have up? Because they had updated guidelines for psoriasis in 2021, I think, maybe even an update in 2022. So how as long as it can take the dermatological folks to have to update this with 3 new drugs. And there's some other stuff like pustular psoriasis and some other
stuff. I mean, derm.
It's big.
There's a lot of new derm stuff, just like boom, 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 coming out.
It's good because we're running out of topics to talk about quick.
Yeah, so we're gonna have a lot of new stuff there.
Good. Just we basically keep our head above water every one episode at a time.
I'll say 1,000 to 1,500 for those creams was actually not as bad as
Yeah, because Eucrisa was probably around that for like the atopic dermatitis and stuff like that. Some of those more
copay
nuanced
cards and stuff like that. That's probably going to be reasonable. It's just get it on some formularies at the beginning of the year. They it's only a few months away from probably getting on some New Year formularies. So
we'll see.
Yeah,
you heard it here, folks. You heard it here first, folks. Is what I was trying to say, and then I just combine my 2 words because I'm sleep deprived. But yeah, so as we've been saying, we'll do a full episode on this and go through all the other treatments and the nuances and the monitoring and everything for the biologics and go a little bit more in depth and not goof around so much. Well, we'll try. But we want to at least make sure we cover the new drugs since there's so many of them coming out before any more get released and we get even further behind. So I hope that was somewhat helpful. AJ, you got anything else you want to add, buddy?
You got a pearl of the day.
Well, AJ, hit me with it.
All right.
I like the SpongeBob right?
Oh yeah, that was pretty cool. The corticosteroids. There is an interactive table listing the topical products and potencies of all of the current available topical corticosteroids. Oh my gosh, I pulled a mic right there, Cole.
What?
Topical corticosteroids.
So disrespectful.
So it goes from class 1 to class 7, from super potent to least potent. And that is a jargon term. That's a medical term, super potent.
Yeah. I've heard, AJ, they used to call you low potency when you were in high school, right?
Stop. Did the super potent ones wear capes?
Yeah, something like that.
Something like that.
I was, that's what's crazy about that. I was just about to say AJ has probably the best voice possible to do like an ad read, and then he insults me like as I'm about to have this positive thought about him. I was like, doggone it. He beat me to it.
Side effects may include.
Yeah, exactly. He needs to put this guy in a commercial. If you guys know anybody.
So pearls.com, PYR.
Yeah, Cole's ready to get out of here. Sorry.
.com.
Pearls.com/core-consult-rx, PYRLS.com. They have all kinds of awesome charts, drug info on them. They're adding stuff all the time. So they've been our biggest supporter from a sponsor standpoint. So we really appreciate them, continuing to work with us. And definitely go check out their stuff and at least get the free app, try it out, see what you think. And you'll get some cool charts and stuff along with it. If If you want more traditional lectures without us goofing around, patreon.com/coreconsultrx is your jam. I'm actually in the process of cleaning up the lectures and stuff so that there's not overlap between like hypertension that I did in 2020 versus hypertension that I just posted this week. So I'm making sure and they'll be labeled by their disease state or cardiology, pulmonology kind of thing, and we'll keep adding a lot of stuff over the next couple months. A lot of new practice questions, a lot of good stuff on there, so check it out. And then other than that, if you have any questions for us, comments, anything, emails, show notes, you can reach us on the social media platforms. The text, you can text the number in the show notes as well. Whatever you want, we'll be happy to talk to you as quick as we can. We'll do our best, but we really appreciate everyone that listens, and we'll catch you guys in the next episode. Everybody have a good night. Bye.